Hello, my name is Kristen Dawson, and today I will be talking about alcohol use in adolescents. I have no commercial financial relationships to disclose. I would, however, like to acknowledge the Kentucky Kids Recovery Grant for funding this educational module in support of the Adolescent Health and Recovery Treatment and Training Project's mission. Ahartt aims to provide Kentucky youth with evidence-based substance abuse treatments and train providers on best practices in adolescent substance abuse treatment. Today's educational module aims to advance the learner's knowledge regarding recognition and treatment of alcohol use among youth. Objectives for this educational module include a review of the prevalence of alcohol use in youth, the risks related to underage drinking, and finally the treatment of adolescent alcohol use disorder with a focus on psychosocial interventions. Pharmacotherapy options for adolescents with alcohol use disorder are emerging, and we will discuss some of these early studies. The expected outcome for this talk is that providers will be motivated to screen for alcohol use amongst their adolescent patients and be better prepared to counsel them regarding the risks associated with problem alcohol use and discuss potential treatment options. I really do want to emphasize the importance of screening adolescents and intervening at an early stage of substance use. I was recently at a national conference where researchers were describing their work in identifying early brain imaging findings in youth with substance abuse and co-occurring bipolar disorder. The moderator praised the efforts to identify the earliest markers for addiction. He went on to explain that it doesn't make sense for clinicians to postpone treatments until patients are middle-aged and hitting rock bottom. He compared it to waiting for evidence of metastatic cancer before offering oncology treatments, as opposed to trying to screen for cancer and treating pre-cancerous lesions. The two substances of abuse getting a lot of attention and capturing headlines right now are heroin and marijuana. Here in Kentucky, there has been legislation and funding to counter the increased number of heroin overdose deaths in the state. Meanwhile, recent legalization of marijuana by some states has brought concerns about increased access to cannabis among youth to the attention of clinicians and public health officials across the country. What seems to have fallen off many of our radars lately, and admittedly mine too, has been underage drinking. Maybe part of the reason for that is due to alcohol use trends for teenagers that have continued to steadily decline. But it should be pointed out that despite the encouraging downward trend for monthly prevalence of alcohol use, binge drinking, and daily alcohol use, there still remains a substantial overall percentage of youth who have been exposed to alcohol prior to the legal drinking age. So while the monthly use of alcohol among 12th graders has dropped from 72% in 1980 down to 51% in 1992, and then below 40% in 2014, we're still left with a significant portion of high school seniors using alcohol. Likewise, binge drinking has also taken a dive from 41% of 12th grade students in 1983 to 28% in 1993 to 20% in 2014. So once again, the trend is an excellent one, but we're still left with a sizable public health concern given that 1 in 5 12th grade students are consuming dangerous amounts of alcohol in a sitting. I should also point out that the decline in binge drinking seen in high school students hasn't necessarily continued on into college. Binge drinking behaviors in college students peaked in 1993 at 40%, with only a 5% decrease in rates by 2014. So certainly high-risk alcohol use is still pervasive on college campuses. Putting things in perspective, the 2014 annual prevalence of use by a 12th grade student for alcohol was 60% compared to 35% for marijuana, 3.6% for ecstasy, 2.6% for cocaine, and just 0.6% for heroin. Now, obviously, I don't want to downplay the concern that state legislators, communities, and healthcare providers are raising regarding the use of opiates or cannabis by youth. But what I do want to emphasize is that even though we have seen encouraging declines in alcohol use among youth, it still remains the most widespread psychoactive substance used by adolescents and young adults. And given how many teens are using alcohol, it is still incredibly important for clinicians to screen for problematic drinking and to consider early treatment and referral. As a provider, I'm currently very concerned with a college student in my practice who has alcohol dependence. She entered treatment for trauma-related symptoms and has been extremely guarded about the extent of her alcohol use. But it has become very clear through the course of her trauma treatment that she has a co-occurring alcohol use disorder, and unfortunately, an early onset alcoholism so beginning before the age of 25 years carries a much poorer prognosis for patients. So next we're going to discuss some of the risks of underage drinking. Certainly of concern is that the use of alcohol in adolescence will progress to an alcohol use disorder later on in life. The National Longitudinal Alcohol Epidemiologic Study demonstrated that alcohol abuse and dependence prevalence rates decreased as the age of first use of alcohol increased. So, if you first try alcohol at age 12 or younger, your lifetime prevalence of alcohol dependence is 40.6%. If you wait until after 18 years of age, that drops to 16.6%. And if you actually waited for the legal drinking age of 21, it drops down further to 10.6%. So you can let your patients know that youth who start drinking before the age of 15 are 4 times more likely to develop an alcohol use disorder in adulthood. The way we define alcohol disorders has changed a bit with the publication of the 5th edition of the DSM. So mental health providers will use the terms alcohol abuse, dependence, and addiction less often, and replace it with the term alcohol use disorder, and then specify whether the symptoms are mild, moderate, or severe. The severity is considered mild if just 2 to 3 symptoms are present, moderate if there are 4 to 5 symptoms, and severe if 6 or more symptoms are present. So that college student I mentioned earlier meets all of the criteria shown here in yellow, and her severity is severe. But despite this, she has had difficulty viewing her alcohol use as problematic because she doesn't experience classic cravings for alcohol use. Additional risks associated with alcohol include health-related risks, and you'll really be hard-pressed to find an organ system that isn't negatively affected by sustained alcohol use. So within the gastrointestinal system, you're at risk for gastritis, stomach or duodenal ulcers, liver cirrhosis, pancreatitis, increased rates of esophageal and stomach cancers. Within the cardiovascular system, there's a risk for hypertension, cardiomyopathy, elevated triglycerides and low-density lipoprotein cholesterol, and an overall elevated risk for cardiac disease. Within the central nervous system, there's a risk for cognitive deficits, severe memory impairment, degenerative changes in the cerebellum, Wernicke-Korsakoff syndrome. Within the peripheral nervous system, you can get peripheral neuropathies. The adolescent brain continues to mature through the mid-20s, including executive functioning. So perhaps counseling a teenager on the long-term cardiovascular risk factors associated with alcohol use may not be an effective strategy. What might be helpful is to use a non-judgmental discussion with information about the most immediate consequences of alcohol use for an underage drinker. So those would be increased risk of premature death. The CDC estimated that alcohol use played a role in the death of 4,358 youth annually, including deaths from motor vehicle accidents, homicides, alcohol poisoning, falls, burns, drownings, and suicide. And as a reminder, the top 3 causes of death for adolescents include motor vehicle crashes, homicides, and suicides. And for all 3 of those top teen killers, alcohol use can play a major role. Alcohol use increases the risk for accidental injury. So in 2010, 189,000 youth were sent to the emergency room for an alcohol-related injury. You can also have impaired judgment from alcohol use, putting adolescents at risk for drinking and driving, high-risk sexual activity, and aggressive or violent behaviors. And youth who consume alcohol are at increased risk for physical or sexual assault. Underage drinkers are also more likely to have legal and academic problems. So this is an actual picture of my front yard from Saturday morning at about 3 a.m. My husband and I woke up to a loud boom and rushed outside. Approaching the scene was an unforgettable experience. I wanted to get there quickly to help, but was terrified about what I would actually find as I got closer and closer to this car. I work in a specialty adolescent substance abuse clinic, so I really do think about the risks of underage drinking all the time, but never has that risk felt quite so real. 5 college students were eventually pulled out of this wreckage. I spent time with the driver as fire trucks and ambulances approached. He was confused, he was frightened and hurt, but what was most distressing to him was gradually realizing that his friends were badly injured and that he had been responsible. These adolescents had been drinking while on campus and decided to take a drive around town. Thankfully, they survived this incredibly bad decision. Adolescent providers are familiar with the risk-taking behaviors that can accompany this developmental period. It may be helpful to think about the profile of an adolescent who's at higher risk for problematic underage drinking. That individual will talk about positive expectations. So it may be pretty obvious, but adolescents who tell you that they expect alcohol to be really pleasurable and a fun experience are more likely to drink than those who see drinking as bad or something that could make them sick. Also, underage drinkers may be able to consume larger amounts of alcohol than adults before they exhibit drowsiness, poor coordination, and withdrawal or hangover. And not only can younger drinkers have fewer negative consequences to alcohol consumption, but they may also be more likely to experience the benefits of reduced social anxiety. Children who drink before age 12 years are more likely to be described as disruptive, aggressive, and hyperactive, or experiencing psychiatric symptoms of anxiety, depression, and withdrawal. Other traits may include rebelliousness, lack of harm avoidance, and disinhibition. Children of alcohol-dependent parents are between 4 and 10 times more likely to develop problem alcohol use as compared to those without close relatives with an alcohol use disorder. So these kids are more likely to start drinking at a young age, and once drinking has started, they're more likely to have a rapid conversion to problematic alcohol consumption. Not surprisingly, views about alcohol held by a teenager's close friends and parents can also play a role in their alcohol use. So parents who consume alcohol and express positive views on alcohol use are more likely to have children who consume alcohol. So let's say you've got a youth in your outpatient pediatric clinic with a diagnosis of ADHD. He's had multiple injuries related to motocross racing and skateboarding accidents over the years, and you find out that he was recently transferred to an alternative school due to threatening his teachers. I'm an advocate for systematically screening adolescents for substance abuse, but with this patient, you're going to start to see a profile that is consistent with underage drinking. The youth is hyperactive, has lower levels of harm avoidance, has started to participate in delinquent behaviors. So he would be an individual with whom you would very much want to screen for problem alcohol use. You might consider asking if his peers drink alcohol as a warm-up question prior to asking about his use of alcohol. And reviewing his family history regarding substance use disorders and discussing views about alcohol with his caregivers would also be important. In a moment, we'll discuss ways to pick up on underage alcohol use at its earliest stages and treatments for adolescent alcohol use disorder once it's developed. It would certainly be wonderful, though, to prevent youth from drinking alcohol altogether. As we've already learned, postponing the age at which you first drink alcohol decreases your lifetime risk of developing an alcohol use disorder. The National Institute on Alcohol Abuse and Alcoholism groups preventative efforts into 2 main categories: environmental and individual level approaches. So let's start off with environmental efforts. These particular interventions work to reduce the availability of alcohol to minors and can include alcohol use laws and penalties, as well as targeting community-level acceptance of underage drinking. So examples would include a higher cost of alcohol. Making alcohol more expensive with higher prices or taxes on alcohol is associated with lower levels of consumption in youth more than adults. The increased minimum legal drinking age of 21. So the National Highway Traffic Safety Administration has estimated that the nationwide legal drinking age in the United States has saved between 700 and 1,000 lives each year from alcohol-related car crashes. Unfortunately, New Zealand has provided a cautionary tale for any proponents of lowering that drinking age. The country lowered its minimum legal drinking age to 18 and experienced a 12 to 14% increase in alcohol-related crash fatalities among its youth 15 to 19 years of age. Enacting zero-tolerance laws. So prior to the widespread adoption of state laws making it illegal for anyone under 21 to drive after any amount of alcohol consumption, it was demonstrated that the zero-tolerance states benefited from a 21% decline compared to their neighboring states in single-vehicle, nighttime fatal crashes for drivers under 21 years of age. Additional environmental interventions include ensuring the enforcement of alcohol laws by monitoring compliance with alcohol vendors, training restaurant servers to check IDs before serving alcohol, enforcing penalties for the use of fake IDs, and placing restrictions on public alcohol consumption, and informing adults about the risks associated with providing alcohol to minors. Let's move on to the individual level interventions. These are directed at youth in hopes of equipping them with the skills necessary to abstain from alcohol. School-based prevention programs do include the infamous DARE program that costs $750 million annually to inform students about the dangers of drug, alcohol, and nicotine use, and was eventually demonstrated to be ineffective in reducing substance use. Newer programs, however, have taken DARE's place with different tactics that include teaching resistance skills to youth and discussions about peer pressures to drink. Family-based prevention programs. So as influential as peers remain in the life of an adolescent, parents do remain important allies in the prevention of underage drinking. The Iowa Strengthening Families program capitalized on parental influence among sixth graders and demonstrated a preventive effect on alcohol use. Family programs work to help parents establish house rules against drinking, improve close monitoring of children's behaviors, and consistently enforce rules against drinking. I've been treating a high school male for major depressive disorder and generalized anxiety disorder. He has a history of experimenting with prescription pills found in his parents' medicine cabinets, smoked cigarettes and cannabis, and has even snorted ground-up nutmeg to achieve a high. And despite entering into our adolescent substance abuse treatment program, his well-educated and concerned parents remain reluctant to place limits on alcohol use for their son. So part of the treatment plan will include ongoing discussions with his caregivers about their views on underage alcohol use and recommendations to place very clear limits on it. The American Academy of Pediatrics recommends that pediatricians routinely screen youth for substance use, provide brief interventions when indicated, and referrals for youth with problematic substance use. Certainly, there are a number of brief screening tools available to providers, including the Audit, which is the Alcohol Use Disorders Identification Test, the POSIT, or a problem-oriented screening instrument for teenagers, the CRAFT instrument, and others. The National Institute on Alcohol Abuse and Alcoholism and the American Academy of Pediatrics work to develop a quick, valid, 2-question screen that can be utilized in a primary care setting. The NIAAA website has a helpful pocket guide and larger reference material to support the implementation of screening, brief intervention, and referral to treatment. You can also find an educational module on SBIRT through our Ahartt website or through CE Central links. The NIAAA alcohol screen involves asking about the individual's alcohol use and about their friend's use. The age of your patient will determine whether or not you start off asking about peer alcohol use first or second. For elementary and middle school age kids, so about 9 to 14 years of age, start by asking, do you have any friends who drink beer, wine, or any drink containing alcohol in the past year? This can act as a sort of a warm-up question to the follow-up, which is, how about you? Have you ever had more than a few sips of beer, wine, or any drink containing alcohol? And remember that having friends who drink strongly predicts the youth's future drinking levels. For high school students, so around 14 to 18 years of age, start off by asking them about the number of days they have had more than a few sips of alcohol in the past year, and then follow up with, if your friends drink, how many drinks do they usually drink on an occasion? So let's say you conduct your screening and your teenage patient reports that they and their friends are all alcohol-free. That's really great. So your role will be to reinforce those healthy choices and to screen again in a year. You may consider providing guidance to parents to maintain strict rules against underage drinking in their home and close monitoring of their child's activities. But chances are you will have many positive screens for alcohol, given that according to the Monitoring the Future study data, about 60% of high school seniors will have used alcohol at least once in the past year. So, for those patients who do endorse any use of alcohol, you're going to want to further assess their risk level. The NIAAA guide that I mentioned provides a risk assessment chart that can quickly risk stratify your patients based on their age and the total number of days in the past year that they had more than a sip of alcohol. Green, or the lowest risk category patients, should be advised to stop drinking. Yellow or moderate risk patients should be provided with the same advice to quit, in addition to the use of motivational interviewing techniques to reduce drinking and a 1-month follow-up appointment. And finally, the red and highest risk patients will require motivational interviewing to promote participation in a specialty treatment referral, as well as the 1-month follow-up with primary care. For those of you unfamiliar with motivational interviewing, it is a clinical approach in which a provider collaborates with a patient to elicit that individual's internal drive to make behavioral changes. So in this setting, provider explores with a patient their ambivalence towards cutting back alcohol use or their ambivalence regarding the acceptance of a referral to a more intensive substance abuse treatment program. Okay, so we're going to move forward with treatment of adolescent alcohol use disorders. The primary treatment approach for adolescent alcohol use disorder involves behavioral and psychosocial therapies. So we're going to review the 4 primary treatment modalities, including family-based interventions and multisystemic therapy, motivational enhancement therapy, behavioral and cognitive behavioral therapies. Okay, so we're going to start off with the family-based interventions and multisystemic therapy. Family-based therapies for adolescent alcohol and other drug use are the most studied intervention. The underlying assumption is that adolescents are most influenced by their families, and a successful intervention is going to have to incorporate an understanding of how that adolescent is functioning within their family and engage that family in the treatment. One of the first studies on family therapy for alcohol and drug use was conducted in 1990 by Lewis and his colleagues. 84 adolescents were randomized to a family therapy treatment or a family-oriented educational intervention. After 12 weeks, the family therapy adolescents demonstrated a lower drug severity index, so 54.6 versus 37.5%, as compared to the adolescents in the educational intervention group. One key element of this treatment modality is to view the substance use disorder as a problem faced by the whole family, not the teenager alone. Youth struggling with addiction may be experiencing shame or may be feeling disconnected from their family. Functional family therapy helps to engage the entire family system in finding solutions together and helps remove blame or negative attributes from the adolescent entering into treatment. Change strategies are implemented specific to a family's dysfunctional behaviors, and adolescents in the family are taught skills to effectively decline substances from peers in this treatment, as well as skills on how to effectively communicate with the family. Here are some of the aims of family-based therapy. So the therapy is going to focus on decreasing a family's resistance to drug treatment. They're going to redefine drug use as a family problem, not a teenager problem. Reestablish appropriate parental influence. Interrupt dysfunctional family sequences of behavior. Assess what the interpersonal function of the drug abuse is. Implement change strategies consistent with the family's interpersonal functioning, and then provide assertion training skills for the adolescent and any of their siblings to resist further peer pressures to engage in substance use. The Lewis study highlights for me the importance of incorporating parents into the treatment process rather than providing them with psychoeducation about drug and alcohol use alone. So I mentioned earlier that I've been a little confounded by parents who were permissive of alcohol use in their 17-year-old son. Providing information about the effects of alcohol and risks involved in binge drinking has not led to changes in the parent's role of regulating alcohol consumption in that home. A family-based therapy, wherein these parents are actively coached on the skills they need to reassert themselves as rule enforcers in the home environment, is going to prove to be more effective. A more recent study of 182 alcohol and cannabis-using adolescents between 13 and 18 years of age were randomized to either multidimensional family therapy, an adolescent group therapy, or multifamily education intervention for 14 to 16 weeks. The end-of-treatment outcomes included adolescent self-report, parent report, and urinalysis. A rating for the severity of drug use was assigned on a scale from 1 to 15, with 1 being no drug use and 15 being marijuana used daily or more, plus other drugs used more than 2 times per week. At the end of this treatment, 42% of the youth in the family therapy group, as compared to 25% in group therapy and 32% in the educational intervention, demonstrated clinically significant reduction in drug use. And at a year, 45% of the family therapy group, 32% in group therapy, and 26% in the educational intervention demonstrated clinically significant change in drug use as compared to the treatment entry criteria. Another really encouraging finding in the family therapy treatment arm was an improvement in academic achievement and family functioning. Functional family therapy has been incorporated into the treatment of adolescent substance use disorders here at the University of Kentucky. Jennifer Connor-Godby is a family therapist treating substance use disorders in adolescents. Here's what she has to say about the treatment modality.
FFT has been proven in numerous settings to be effective for the treatment of youth with a range of risky behaviors, things like criminal activity, out-of-control behaviors at home or at school, violence, substance abuse, and others. Through the Kids Recovery Grant, we've had the opportunity to get certified in this treatment protocol so that it will be offered here permanently. The treatment is open to youth and families who are concerned about a new or existing substance abuse and or other problem behaviors in adolescents. Myself personally, having worked with teens in trouble for the past 13 years, I know the difficulties that many families and institutions face in trying to find help that works. I've found that this treatment approach offers a viable alternative to more intensive or long-term individual treatment options. For example, one family I'm working with right now has been in outpatient therapy and psychiatric care for about a decade with their son. And this is the first time that the parents report that they are involved in the treatment working on their own part, which is a subtle but important difference that makes FFT unique and separate from previous approaches that may be focused more on teaching parents skills that might help them parent their adolescent differently. This family, for example, has been successful in changing a pattern of interacting that's made working together much more feasible. In general, FFT focuses on removing blame and negativity and replacing that with an alliance between all the family members and the therapist to identify and implement new skills that work for them to accomplish their common goals. As you can imagine, it's not uncommon that everybody in a family wants for an adolescent to become independent and self-sufficient, and they all have different ideas of getting there. Perhaps anger, blame, and the hurt it has caused have kept them from working together. Using FFT and learning conflict management skills and problem solving in ways that fit each family's unique values, culture, and style makes working together possible. The primary distinction that sets this approach apart is the focus on the family. Everyone participates in each session after the initial interview, and most interventions last for about 12 to 16 sessions once per week. First phase is focusing on understanding problems and issues and patterns that have the youth and family stuck and getting motivated to make the changes. Then we identify specific behaviors to target in the pattern that's going on. We learn the skills and tailor them exactly to your particular family and work on changing those patterns and things that are getting in the way. Everyone in the family learns something new they can do differently to help in the second phase, and then we work on generalizing those skills to other settings, the community, the school, where interactions with peers and other things that people are concerned about.
Earlier, we discussed briefly the use of motivational interviewing in the context of enhancing an adolescent's internal motivation to reduce alcohol use or to accept a clinician's recommendation to enter into an alcohol treatment program. Motivational enhancement therapy and motivational interviewing have been evaluated as a brief intervention to promote reduction of alcohol and other drug use in adolescents. A group at the University of Washington identified college freshmen who were at high risk for alcohol use disorders based on their self-report of high school alcohol consumption. 188 female and 160 males were randomized to receive just one motivational interviewing session during the winter of their freshman year in college. An interviewer provided personalized feedback about the students' drinking patterns, risks, and beliefs about alcohol effects as compared to college averages. The interviewers maintain motivational interviewing principles of actively expressing empathy, developing discrepancy between the patient's goals and values and their current behaviors, rolled with the resistance, and they promoted a patient's self-efficacy. Incredibly, the researchers demonstrated that the high-risk college students who received this one-time brief motivational interviewing session showed significant reduction in alcohol consumption rates and harmful consequences of alcohol use as compared to the control group at 6 months and even at a 2-year follow-up. So this study came to mind this weekend as I thought about the freshmen who wrecked their car in front of my house after a night of drinking. To think that just one session of motivational interviewing with these high-risk college freshmen could have had a significant impact on their drinking 2 years later is really pretty incredible. Another team of investigators randomized 200 16 to 20-year-old participants to a single motivational interviewing session or a single educational session. A 3-month follow-up demonstrated that the motivational interviewing group exhibited a significant reduction in nicotine, alcohol, and marijuana use as measured by self-report, peer interview, and hair sample analyses. Effect sizes for cigarette reduction was 0.37, alcohol was 0.34, and 0.75 for cannabis use. Furthermore, there were 28 non-drinkers identified at the study's baseline. Just 1 youth in the motivational interviewing group and 12 youth in the control group began drinking during that 3-month follow-up period. The third psychosocial modality for the treatment of adolescent substance use is behavioral therapy. Behaviorists consider what happens before a given behavior, the antecedents or triggers. They then dissect the actual behavior and then look at the aftermath or the consequences of a given behavior. This functional analysis of drug or alcohol use can be helpful to the adolescent in reducing the number of times they engage in alcohol behaviors. For example, I took care of a young man on the inpatient psychiatric unit with a cannabis use disorder. He was able to discuss in detail the environment and the various stimuli that led to his most recent purchase of marijuana. One environmental trigger for this young man was simply walking past a large public park near his home after school. That happened to be where his dealer set up shop. So an intervention for him included deciding on a specific alternative route home that circumvented the park altogether. Behavioral therapists may also work with teenagers on the skills they need to refuse drugs, the skills they need to manage anxiety or stress, and how to regulate their emotions and assertiveness. One of the early studies of behavioral therapy for treatment of alcohol and other drug use in adolescents was conducted by Ahartt and colleagues. 26 youth ages 13 to 18 were randomized to a behavioral therapy treatment arm or supportive counseling. Each group included an average of 15 sessions over 6 months. Urinalysis results demonstrated abstinence in 73% of the youth receiving behavioral therapy versus just 9% in the supportive counseling arm at the end of treatment. The behavioral therapy participants also self-reported less frequent drug use, improvement in their ratings of conduct, youth-parent relationship satisfaction, decreased frequency of alcohol use, and reduced depression. One of the 3 main interventions included devising a specific and individualized list of safe and risk situations for each subject. So, for the example I gave earlier, a walk near the public park would certainly make it on his risk list. But there are a number of other situations in which he was more or less likely to use. So the behavioral therapist would then work with the youth to keep track of how much of their daily life was spent in the safe or the risk settings and work to improve the majority of their time to the safe list. Finally, an extension of behavioral therapy is cognitive behavioral therapy, in which the functional analyses of substance use behaviors are identified, as well as associated cognitions and emotions. Kamner and his colleagues randomized 32 youth with co-occurring psychiatric disorder and substance use disorder into 2 12-week manual guided outpatient group therapies, CBT versus interactional group therapy. The study authors were interested in matching a co-occurring psychiatric illness, like depression, conduct disorder, ADHD, with a response to CBT versus the interactional group treatment arm. Regardless of the comorbidity, the adolescents assigned to the group CBT demonstrated a reduction in the severity of substance use as measured by the Teen Addiction Severity Index, though there were no differences in urinalysis results between the groups. Here at the University of Kentucky, our adolescent substance abuse clinic offers youth and their families either functional family therapy or an adaptation of CBT as developed by Dr. Paula Riggs at the University of Colorado. Dr. Riggs's Encompass CBT program includes manualized individual CBT with between 2 and 4 family sessions, motivational incentives for clinic attendance and abstinence as determined by on-site urine drug testing, and the promotion of pro-social community-based activities during a 16-week treatment course. Here's a video of Dr. Riggs discussing the cognitive behavioral therapy for the treatment of youth with psychiatric comorbidities and substance use disorders.
So we know that many of the adolescents we see for substance abuse problems come in with comorbid disorders like depression, ADHD, anxiety. Could you comment on how you stage treatment for the substance use and the co-occurring disorders?
You're right. Kathy, we know that almost all of our patients, really the vast majority, it's the rule and not the exception that they would have a co-occurring psychiatric disorder. And you mentioned the most common, attention deficit hyperactivity disorder, depression, or an anxiety disorder. And so since it's the rule, not the exception, it's critical that clinicians evaluate at baseline, assess that to know whether those are present. And you really want to treat the substance use disorder and the co-occurring psychiatric disorder in a concurrent or integrated fashion.
So if someone comes in for the treatment for adolescent substance abuse and you diagnose depression, you start with the treatment for the substance abuse first and see how that treatment affects both disorders, or could you?
Or start with the depression treatment and then the substance. So, I mean, the question really is sequential treatment or concurrent? Do you really do it together? The way I think about it, and sort of the way the science and the research has been emerging, would say, in general, as a general rule, we ought to address them both together, because we know that unless someone is psychotic or really debilitated from their psychiatric illness, that needs to be stabilized first. If they're in acute withdrawal from opiates or whatever, you've got to stabilize that acute distress first. I mean, so barring those two conditions, you know, it's depression, but it's not really psychotic. And so you would really want to treat both together. So the way you approach that, we know, for example, the traditional model has been sequential. We know how to treat depression, but often clinicians would refer to substance treatment first if they also have a substance disorder to get treated in substance abuse, to get a sustained period of abstinence under their belt before they're considered to be treated for their depression. That's probably the reason why kids or adults have poor outcomes, because we know that if you go to substance treatment, it's hard to be successful. Under the best circumstances, if you have an untreated Axis I mental illness, it's even harder to be successful. And so treating them concurrently, the substance abuse exacerbates the clinical course or complicates its management of depression or ADHD and vice versa. So how do you treat them together? It turns out that some of the research that's really a growing body of research emerging, that if you're treating substance abuse, for example, with individual cognitive behavioral therapy, the research suggests that they may generalize that so that the depression symptoms or ADHD symptoms or anxiety symptoms might come down in response to the CBT, even if it's addressing largely substance. But if it doesn't, if in that first month of treatment you don't see the symptoms of the co-occurring disorder coming down, we now have research that shows that clinicians can treat with medications that they would normally treat depression with or ADHD with, such as long-acting stimulants, Concerta for ADHD, or atomoxetine. Fluoxetine, as an example, has a good safety profile for depression, even in kids who aren't yet abstinents. And I'd say that the caveat would be, if you need to use a medication, look to the literature, the ones that have been shown to have some efficacy and good safety profiles in kids who have substance use disorder, and treat that disorder with a medication if it's not responding to CBT in the context of ongoing substance treatment. So if they're coming to substance treatment and you're treating the depression, monitor both together. That's what the current research would support.
Many of you who work with adults with alcohol use disorder are familiar with pharmacotherapy options for this population. For acute alcohol withdrawal syndrome in adults, benzodiazepines are utilized. Additionally, 3 medications have FDA approval for maintenance therapy in adults with alcohol use disorder: naltrexone, disulfiram, and acamprosate. We're starting to see medication trials involving adolescents emerge. The very first studies focused on safety and tolerability of medications used to treat mood disorders in adolescents who had a co-occurring alcohol use disorder. Then later studies have started to investigate medications that target alcohol cravings, provide aversive response to use of alcohol, and support abstinence from alcohol. Today, we will talk a little bit about naltrexone and disulfiram studies in adolescents. You may be wondering if the third FDA-approved drug for adults has been investigated in the adolescent population. Unfortunately, an adolescent trial of acamprosate published in 2003 has since been retracted due to a copyright violation. In its place, however, we will discuss ondansetron in the treatment of early onset alcohol use disorder. Furthermore, I'm unaware of any trials investigating the safety and efficacy of benzodiazepines for alcohol withdrawal in youth. Severe alcohol withdrawal symptoms may be less common in adolescents, but initial withdrawal symptoms may occur and can include fine motor tremor, dysphoria, and increased blood pressure and heart rate. None of these medications have FDA approval for use in patients under 18 years of age, and it should be emphasized once more that the psychosocial interventions remain the primary treatment for alcohol use disorder in adolescents. Disulfiram, or antabuse, was investigated in 2003 among 26 adolescents between 16 and 19 years of age in a double-blind, placebo-controlled study. Disulfiram's mechanism of action includes inhibition of aldehyde dehydrogenase. If an individual relapses and consumes alcohol while taking disulfiram daily, he or she will experience a sudden increase in blood acetaldehyde levels. Those elevated acetaldehyde levels make folks feel very sick. Symptoms include nausea, flushing, chest pain, palpitations, vertigo, thirst, and hypotension. The experience is certainly an unpleasant one, and this aversion to the reaction is what promotes continued abstinence in the patient. In the adolescent study, 26 patients were randomly assigned to disulfiram or placebo after at least 5 days of sobriety from alcohol. The active arm received a total of 200 milligrams daily of disulfiram. At completion of the 90-day treatment, 2 placebo-treated youth versus 7 disulfiram-treated patients had achieved continuous abstinence. As well, the disulfiram group's mean cumulative abstinence duration was significantly greater than the placebo group, so 68.5 versus 19 days. Of note, the authors reported no differences between the groups in reporting of adverse effects. The authors of this study suggest that the use of disulfiram in an adolescent with alcohol use disorder may be considered, but perhaps ideally implemented in a specialized treatment facility. Certainly, youth will require informed consent. As well, patients with medical comorbidities may not be eligible for disulfiram. Baseline liver function tests and monitoring is required due to the risk of hepatotoxicity. Other rare but serious adverse effects include arrhythmia, respiratory depression, toxic hepatitis, seizures, and death. The next medication we will discuss is naltrexone. An open, randomized trial of disulfiram versus naltrexone for adolescents with alcohol use disorder has been conducted, and not to spoil it for you, but disulfiram came out slightly ahead. 58 adolescents were randomized to disulfiram or naltrexone and provided with weekly psychoeducation for 6 months. Although the naltrexone group reported less alcohol craving, the disulfiram group reported 79% abstinence during the study versus 51% with naltrexone. And the mean days until relapse was 84 days with disulfiram versus 51 days with naltrexone. Despite disulfiram coming out slightly ahead in one study, I must admit that I have some reservations about the use of an aversive agent in the treatment of alcohol use disorder. And when you talk to some of your patients about disulfiram, you may find that they too are reluctant to take a medication that will make them sick if they relapse. An alternative potential pharmacotherapy to support alcohol abstinence in youth is naltrexone. Naltrexone's mechanism of action is that of a partial opioid antagonist and may reduce cravings associated with alcohol use. Like disulfiram, it also carries a potential for hepatotoxicity and liver function monitoring should be conducted. As well, naltrexone is contraindicated in patients who are prescribed opiates for pain, as it can precipitate an opiate withdrawal syndrome. The initial studies on naltrexone in adolescents with alcohol use disorder included a 6-week open-label trial with just 5 participants administered 50 milligrams naltrexone, and 2 case reports describing 3 patients administered naltrexone for 12 weeks. So if you're keeping count, that's a total of 8 youth altogether. More recently, a randomized double-blind placebo-controlled crossover study examined the use of naltrexone and placebo in 22 adolescents ages 15 to 19 years. 2 participants withdrew from the naltrexone treatment arm due to complaints of nausea, loss of appetite, and vomiting. Naltrexone administration had a small effect size on drinking days and heavy drinking days. The youth administered naltrexone consumed alcohol on average 2.4 days, as compared to 3.1 days with placebo. The authors also found that naltrexone blunted cravings for alcohol, both in the adolescent's natural environment as well as in a laboratory setting. When the adolescents did consume an alcoholic drink, those in the naltrexone treatment arm reported lower stimulation and greater sedation compared to the placebo, but the naltrexone group experienced a heightened subjective high from alcohol. Ondansetron is used for the treatment of chemotherapy-related nausea and vomiting and is a 5-HT3 receptor antagonist. It may seem like an unlikely choice for treatment of alcohol use disorders in youth. However, it appears that early onset alcoholism, so 25 years and younger, is associated with serotonergic dysfunction. Researchers at the University of Texas Health Centers in Houston and San Antonio randomized 271 individuals with alcohol use disorder to receive 11 weeks of treatment with 1 of 3 doses of ondansetron or placebo. They found that the subgroup of alcoholics with early onset alcoholism had fewer drinks per drinking day, when receiving ondansetron. Research subjects were between 25 and 65 years of age at the time of the study. So building on the promise of its efficacy in the treatment of early onset alcohol use disorder in adults, researchers conducted an 8-week prospective open-label study of ondansetron in 12 youth aged 14 to 20 years of age. Dosing of ondansetron was 4 micrograms per kilogram twice daily, and subjects also received weekly CBT with motivational enhancement. Unfortunately, half of the sample size dropped out of the study by 8 weeks, but none reported adverse effects of medication as their reason. Ondansetron was well tolerated in the youth with no serious adverse effects. And over the course of the study, participants reported a decline from 3.06 drinks per day at baseline down to 1.3 drinks at 8 weeks, and a decline from 7.57 drinks per drinking day down to 3. Certainly the results of this study are promising with respect to safety and tolerability of ondansetron, but the authors recommend future double-blind randomized controlled studies in adolescents. Okay, so those are the studies exploring pharmacotherapy options for adolescent alcohol use disorder: disulfiram, naltrexone, and ondansetron. Keep in mind that disulfiram and naltrexone are FDA approved in adults, but none of these have FDA approval in adolescents as of yet. I have to say that I'm particularly interested in future placebo-controlled trials of ondansetron for early onset alcoholism. This group is defined as patients with problem drinking that begins before age 25 years, and it's distinct in that their prognosis is poor because of more severe progression of the disorder, more severe comorbid psychiatric disorders, and poor overall response to substance abuse treatment. They're more likely to have a family history of alcoholism and have evidence of serotonergic dysfunction as compared to the later onset alcoholics. There's also growing evidence that ondansetron may be of clinical use in this subgroup of alcohol-dependent patients. I'm currently treating a patient who just turned 21 years of age and has a co-occurring post-traumatic stress disorder, in addition to her alcohol use disorder. She does fit this profile of an early onset alcoholic in that her mother has an alcohol use disorder, she has a psychiatric comorbidity, and her progression of illness has been rapid, with 3 lifetime alcohol-related withdrawal seizures, 2 recent medical hospitalizations for alcohol detoxification, 2 recent motor vehicle accidents while driving under the influence, and suicidality that emerged with intoxication. During the course of her outpatient treatment, she has declined recommendations for a higher level of care, including inpatient substance abuse treatment or an intensive outpatient program. At this time, she's only willing to participate in trauma-focused cognitive behavior therapy, while her therapist and myself work to also include motivational interviewing techniques into our sessions. Again, if you're considering the use of one of these medications, certainly spend time discussing the risks, benefits, alternatives, and side effect profiles with your patient and their guardian, all the while emphasizing the great importance of the psychosocial interventions. Certainly, you will encounter youth who may have a co-occurring psychiatric disorder in addition to problematic alcohol use. In fact, about 60% of adolescents who meet criteria for a substance use disorder will have a co-occurring psychiatric disorder. We have evidence from one study that adolescents with bipolar disorder and alcohol or other substance use can be treated with lithium. The authors found that lithium was well tolerated by patients, and while the mood outcomes didn't differ from placebo, the lithium-treated patients had fewer positive drug screens and greater clinical improvement. Another small study investigating pharmacologic treatment of a mood disorder in adolescents with substance abuse was conducted. In this study, 10 youth with comorbid depressive disorder and alcohol use disorder were treated with sertraline or placebo with cognitive behavior group therapy. The data demonstrated overall safety and tolerability of sertraline, but there were no significant differences in treatment outcomes between the groups. More recently, fluoxetine has been studied in adolescents with a depressive disorder and alcohol or other drug use disorder. Study results were mixed overall, but fluoxetine was tolerated in the dually diagnosed adolescents. So it may be reasonable to initiate cognitive behavior therapy with motivational enhancement in youth with depression and a substance use disorder, and then consider adding fluoxetine if the depressive symptoms are not responsive to treatment. And do keep in mind the black box warning for suicidality. Tying it all together, I'd like to once again remind you that alcohol is by far the most commonly used psychoactive substance used by youth. Among United States 12th grade students, 60% are using alcohol as compared to 35% using marijuana, 3.6% ecstasy, 2.6% cocaine, and 0.6% heroin. I'd encourage you to consider screening your adolescent patients for alcohol use and consider a brief intervention for those adolescents who have low risk use of alcohol. For those who are in a higher risk category, I'd encourage you to make referrals to providers who are practicing one of the evidence-based psychosocial treatments, including family-based interventions and multisystemic therapy, motivational enhancement therapy, behavioral therapy, and cognitive behavioral therapy. And consider the importance of treatment of co-occurring psychiatric illness in the 60% of youth who have a dual diagnosis. As well, you may encounter patients who are involved in psychosocial interventions, but who might also benefit from an adjunctive pharmacotherapy. Here at the University of Kentucky, our Ahartt clinic offers functional family therapy as well as Encompass cognitive behavior therapy, along with weekly drug testing, a timeline follow-back procedure, and contingency management, as well as psychiatric evaluations for those co-occurring disorders. We'll be adding peer supports for those in recovery to our program as well. For more information about our clinic or to make a referral, visit our website, www.ukahartt.com. And thanks for listening.